Alisdair, McNeill, as Martin said. I spend part of my time offering a clinical service to people with inherited brain diseases and part of my time working in genetics research at the University of Sheffield. So I'll start with a picture of some chins, and there's a good reason for showing you some chins, and also a picture of a gene. What is a gene? There's nothing special about a gene. A gene is just an instruction for a part of our bodies. We're not really sure how many genes we've got. If you say 20,000, it's a clear Starmer defensible statement. Not quite true, but not quite a lie. As you've heard today, genes make instructions or proteins. Most of our genes come in a pair, one in each pair from mum, one from dad, apart from the genes on the Y chromosome, because men have only got one X chromosome. Chins illustrate a number of things. At high school, you were taught that the cleft chin is a dominant trait. Your dad's got a cleft chin, you've got 1 in 2 chance of inheriting that cleft chin yourself. But then actually we realised it's all a load of rubbish, and cleft chins are not that simple. They're polygenic, and it's the influence of hundreds of different genes that determine whether you've got a cleft chin or not. And that's the same for every single part of your body, really, and for most diseases. For most diseases, it's not down to just whether you've got a particular letter in a gene or not. It's a more complicated interaction than that, which you've heard about today already. Okay. And this is from Rachel Horton in Oxford. So if you want to think about disease risk, we've got a bucket of risk, and some of us have more pebbles of that in that bucket at birth, and that's your genetic risk. And the rest of the risk fills up with environmental factors until you may or may not develop the disease. And the missing link for MND is that we don't really know what the environmental risk factors are. That's genes. What's genetic counselling? It's an unfortunate term. It's a historical term. It's not really counselling in the sense you might understand nowadays. There's no real psychological support or in-depth discussion about your emotional health or how to cope. It's a focused discussion about understanding what the genetic risk in your family means to you and how genetic testing may or may not help you clarify that risk. And in the UK, genetic counsellors go through a 2-year training programme. They're not doctors, they're not nurses, they're a distinct group of professionals, which isn't the same in North America or Australia. So in different countries, you might get slightly different skill sets in people who call themselves genetic counsellors, which can cause confusion. Okay. And I think you've seen this sort of graph before today. Over the years, we've recognised more and more genes which can cause motor neuron disease within families. There's probably 60 or 70 genes now which have got good evidence for them. And also in sporadic, apparently non-familial families, these genes also occur, probably for reasons of non-penetrance, as Dr. Douglas said. And depending on what you read, if you've got a strong family history of motor neuron disease, some studies say you might have up to a 3/4 chance of having a detectable single gene cause, and maybe a 10 to 20% chance if you've got no family history of a clinical genetic test finding an identifiable cause. Okay. The genetic testing in motor neuron disease is complex. We can't just test one gene. We have to use a test called whole genome sequencing, which reads all of the genes and all of the bits that turn genes on and off, and all the other bits of the genome that we don't fully understand. And we're very lucky that in the past few years that's become routinely available in the NHS, although there are barriers and hurdles to accessing it and getting a report. There's no other healthcare system in the world which offers such universal access to whole genome sequencing. So it's something we can genuinely see as a positive. So in MND, there's lots of different genes you have to test. A significant portion of people with MND will have more than 1 or 2 genes with possible causal variants in them. Sometimes the family history is difficult to assess and ascertain. And so why would we like to have genetic testing? Well, the reason everyone wants to have genetic testing is to access a treatment such as tofersen for SOD1, or possibly access a clinical trial. But there are broader, more conventional genetic counselling reasons, such as sometimes people just want to understand why they've got a disease. They might want to understand the risk to their relatives, and there can be reproductive implications. People can access forms of IVF to make sure they don't pass the genetic risk factor in the family down to the children. Okay. So you probably recognise this. This is a pedigree. It's what we draw in clinic. Circles are people who assign themselves genetic females. Squares are genetic males. If you shade a symbol in, it means someone's affected. So this is unarguably familial MND. There's 3 generations. Multiple different people have all had the condition. And to start off, to find out what's caused MND in this family, you'd offer whole genome sequencing to one of the affected individuals. And you'd then offer, if they were interested, what we call predictive genetic testing for an affected relative. But what often gets forgotten about is to get to that stage where you can offer genetic testing to other relatives or any other information, you need to cascade that information throughout the family. And that's really tricky. And within the UK, we don't have any good infrastructure for doing that. Clinicians cannot directly contact relatives unless it's absolutely exceptional circumstances and someone's life is essentially at risk. So we have to think about better ways of the health service supporting information sharing within families. Okay. So that's some of the reasons why it's difficult to do genetic testing for MND. The other reason is the science. If you find a change in a gene, as Andrew Douglas has alluded to, it's difficult to work out sometimes if that genetic change, that mutation really is causing a disease, or it's just part of the natural variation you see in genes from one person to the next. And this heat map on the top right of the screen, as you look at it, is from hundreds of thousands of genome sequences from people in different populations in the world. And just by looking at people's genetic sequence, you can get quite fine-grained information as to where they came from. So you might not be able to see it, but people from Finland and people from Sweden are almost completely distinguishable just by sequencing their whole genome. And it's very difficult to work out whether variants you find in a patient clinically are just ancestral or whether they're disease-causing. We've got better at it over the years, but it's still not perfect. The other complicating factor is that genes, we know what they are. We can probably only read the code of about 90 to 95% of our genetic letters. There are 3 billion letters in the genome, and some of them are buried in these regions of the genome which we can't read with current sequencing because of chemical reasons, or we can't read with current clinical grade sequencing. And undoubtedly, we're missing some of the heritability in there. Okay. There's man-made barriers as well. This is the forms you have to complete to access whole genome sequencing to request a test for someone with MND in the NHS. All the points on the form that you have to sign off on, they're all perfectly valid and important to discuss with the patient. Really difficult to manage in the context of a busy neurology clinic. And we did a survey of MND care centres, which people indicated they were not a big fan of this system, and there are obvious barriers and issues to using it. So the scientific reasons that make it difficult to do clinical whole genome sequencing, there's NHS and procedural reasons, but it's still, I think, really important to at least discuss it with families, because there are concrete benefits at lots of different levels. Okay. Something that often causes a bit of friction is, why do we have to have an identified gene to offer predictive testing to relatives in families where there can be multiple people with MND? Andrew gave you the answer to that. In the normal population, perfectly healthy people can carry apparently pathogenic mutations in almost all of the MND-linked genes, and if we're to offer a test blindly to a relative, we might find an apparent mutation in SOD1 and tell them they're definitely going to get MND, when in fact this variant might turn out to be nothing to do with the causation of MND in that family. So we have to be really careful in offering genetic tests within families and be very sure of our system. The system that's built up in the NHS, it's cumbersome, it's boring, I'll talk about it in a minute, but it's built upon decades of experience with Huntington's disease families, and we know it's as safe as can be in this situation in terms of protecting people from significant psychological harm. Okay. So how does predictive testing work? It's a good diagram, I didn't make it, Claudia, you made it, give it a few sentences. I'm going to replace us all. So at the top left, the pedigree, again, grandfather and father both got MND, clinically ascertained, you've got clinic letter, it's definitely a diagnosis. There's a SOD1 variant which has been seen time and time again in families, so it's as nailed on as it can be, this is dominant genetic MND. It's technically very simple to sequence that gene and tell any of the grandchildren whether they've inherited it or not, but it's the psychological impact on people's lives that genetic counselling is concerned with. And so historically it's been offered in at least a 3-stage process where you first meet the counsellor and they discuss your understanding of MND, why you might want to have the test, what the benefits are to knowing your status and not. A couple of weeks of cooling off, a second visit to discuss with the same person to check your choice remains stable, and then have a blood sample taken, and then a follow-up visit to get the result. Where the NHS system starts to fall down is that for people who've had a predictive test and they've got a mutation in any gene for any condition, there's no real services for people to go into thereafter. There's no NHS pre-MND clinic for people who carry a genetic variant, nor is there for Huntington's or BRCA or any other genetic condition. Does this take time? Families often express frustration, they just want to know the answer, but as clinicians we know that following this process minimises psychological harm to families. And in the early days of Huntington's testing, there are anecdotes of people who tested positive and tried to commit suicide or use an unwise act. So there's a possibility of adverse psychological impacts. And it's difficult for us to switch away from something we know is safe and do something quicker and apparently easier, because then we'd be taking responsibility for doing that if someone came to harm. And that's my perspective as a doctor. Okay. So we've just talked about why it's complex, time-consuming and difficult to offer testing, both for people with MND and their relatives. And as a response to this, we've developed these things called patient decision aids, which don't solve the problem, but hopefully start to address some of them. This is a team that was involved. Our aim was to make these patient decision aids, and we did research to work out what families needed in terms of information support, and likewise what clinicians would benefit from in terms of another information resource. Patient decision aid can be anything. It can be a leaflet, a website, an app. It presents information and sort of balancing exercises to help people decide between competing choices. And there's lots of evidence across different healthcare settings that people who've used patient decision aids feel less decisional conflict when they're surveyed thereafter about the choices they made. Okay. Why decision aid? In the NHS, there's lots of guidance about when to offer testing, who you can offer testing to across various diseases. There's very little in NHS guidelines about how to support patient choice. And that's why we decided to focus upon using decision aids, and they're also evidence-based. So the process started with interviewing some families, doing some surveys of clinicians to identify what the information and support gaps were, then combining these together to make prototypes of the decision aid with advice from a steering committee and our local IT company. Various prototypes of the decision aid were made and then went through user-centered co-design process and focus groups to try and iterate and design the final version. Just for interest, this is the information we got from the studies. People with MND and family members had great variability in recounting what their experience was. Most of them had unanswered questions even after they'd been delivered their test result, and people expressed the need for more balanced, reliable and accessible information. Healthcare professionals articulated a lack of consistent information resources they could hand out to patients, and there were numerous service barriers to offering whole genome sequencing, as we've alluded to. Yeah. And if you're interested in looking up, here's some of the papers. They're in medical journals, but they're actually quite accessible. They're based upon patients' experiences and what they've said to us, and they're freely available. This just reiterates the iterative process of going through focus groups to refine an intervention. This is what we made. There are my MND gene test. There's a distinct one for people with MND and one for predictive testing, because the issues are different and the testing process is different. And we'll focus on the predictive testing one. So they all follow a consistent formatting, section A and B, C, D. C and D are simple information. A is trying to present the pros and cons of given courses of action. Section B is more interactive, helping people to refine their decisions and any further questions they might have. And we do clearly foreground in this decision aid that in current NHS practice, you have to be aged over 18 and have a relative with MND who's got a genetic variant detected before you can access this pathway. And throughout the decision aid, we use very clear diagrams, keeping everything neutral so as not to unintentionally weight people's decision in one way or another. There's spaces for people to reflect on what they are thinking about and to write notes so they can take back to the clinician, factual presentations, and then towards the end, like style responses where people can click through to try and work out where they're leaning towards in terms of decisions. As an example of some of the information we give. That's been developed, it's undergone early usability testing as part of the focus groups, and Jade's taken out to some clinical centres to see what clinicians think about it. Relatives of people with MND were generally positive about it, said it was balanced, comprehensive, they found the information to be accurate and reliable, and valued interactivity. It's very difficult to get absolute consensus from everyone about how things should be formatted and presented, so things are a balance of different opinions, as you'd expect. Clinicians don't really feel ready to integrate this into practice. For understandable reasons, it's quite a new tool. Some MND clinics have been using it in the care centres, about 4 or 5. One concerning point I picked up on was that consultants felt this might delay access to whole genome sequencing if you use a decision aid. We're not stipulating where you use a decision aid or how you use it. You can have a bare bones discussion about MND genomics in clinic, sufficient to get the test done, and then give them access to this, and then they can access this whilst they're waiting for the result, so they're more prepared to understand the implications of a positive or negative result and actually make the consultation you have with them more efficient and aid their understanding. This is just a little snapshot of a little bit of clinical genetic research that's going on within the wider M&D research group in Sheffield. There's lots of people to acknowledge who you can read about. And I'd particularly like to thank Jen Bedford of the M&D Association, who gave us lots of helpful input in setting up our steering committee, and Stella McKernan, also at the association, who's lobbying for improvements to how we offer whole genome sequencing on NHS to M&D patients, and hopefully that will come to fruition, particularly around the speed of testing. Speed of testing has come down. Anecdotally, when it was launched, you could be waiting up to 12 months for a WGS result. At most centres now, it should be 3 or 4 months. Okay. I'll finish there. Thanks very much.